Hello, welcome to today's webinar. My name is Dr. Dan Kim. I practice emergency medicine at Vancouver General Hospital. I'm also a clinical associate professor and the point of care ultrasound fellowship director for the Department of Emergency Medicine at UBC. It is my pleasure to moderate this webinar today. Our webinar topic was independently conceived by the Scientific Planning Committee, consisting of Drs. Eddie Lang, Stacy Kitts, Kirit Grewal, and Peter Heraclius, none of whom have any conflicts of interest to declare. I have to disclose that I'm on the Medical Advisory Board of Clarius Mobile Health, but I won't be mentioning any of their products or devices, so this should not lead to any conflicts of interest for this talk. This presentation is made possible by an education grant from City. All efforts are made to mitigate any potential bias. A little background on this webinar's development. So heart failure is something we see commonly in the emergency department. CAPE sent out a needs assessment to the membership to find what in with failure. Heart management may not have changed much in recent years. There are some updates in the way we approach diagnosis, disposition, and pharmacologic therapy. As such, our learning objectives are 1, to support the diagnosis of heart failure using point-of-care ultrasound. 2, to integrate risk scores and discharge planning into disposition decision-making for emergency medicine patients with heart failure. And 3, recognize the impact of new and old heart failure medications on patients in the emergency department. So to increase the interactivity of this session, we encourage you to use the chat feature to submit your questions, and we'll try to address as many of them as we can. We'll also be doing some audience polling during the webinar. For that, you'll need to have access to the Mentimeter website. So there are 2 options. You can either access the website directly at menti.com and enter the code on the screen, or you can scan the QR code. You'll be prompted to enter the code on the screen and then answer each question as it comes up. So I'm delighted to be joined by 2 excellent speakers and 2 experts today, Dr. Sean Collins and Dr. Jonathan Howlett. But first, I'd like to tell you a little bit about the use of point-of-care ultrasound in heart failure in the emergency department. So before I start, I want you to all answer the poll question. Do you use point-of-care ultrasound in the workup of undifferentiated shortness of breath or heart failure in your practice? So we'll give you folks about maybe 20 seconds or so to answer the poll question. Okay, so far we have 6 responses. Okay. Yeah, okay, it's tracking upwards. Yeah, so like I said, go to the website, enter the code. Do you use point-of-care ultrasound in the workup of undifferentiated shortness of breath or heart failure in your practice? Okay, we'll probably give it a few more seconds, maybe 10 more seconds. Okay, we might as well trigger the results and sort of see what they look like. Okay, so it's about 50-50, maybe just over half of you have said yes. So I'm going to go ahead and change screens. Okay, so you should be able to see my screen. So, I mean, the poll results are sort of interesting. It's split maybe 50-50. So really the question becomes, why use point-of-care ultrasound at all? So I think there's actually pretty good evidence for using it. So this was a systematic review meta-analysis published earlier this year in the American Journal of Cardiology. So these authors identified 8 studies with a total of almost 2,800 patients. And they essentially found that long ultrasound had both high sensitivity and high specificity for diagnosing heart failure, clocking in at 92% for both. And in fact, most of the studies also involved chest radiography as well. And they compared the 2, and they found that long ultrasound was more sensitive than chest X-ray, 92% versus 77%. What that means is that for 100 patients presenting with heart failure, long ultrasound can diagnose 16 more cases than chest X-ray without an increase in false positives. The other reason long ultrasound is so useful is that the clinical assessment is actually quite suboptimal. Here are the positive likelihood ratios of typical history and physical exam findings in heart failure. For those of you who are not stats nerds, remember, you need a positive likelihood ratio greater than 10 to significantly alter your post-test probability of disease. As we can see, Orthopnea, PND, jugular venous distension, Ralls, they all have pretty mediocre statistics. On the other hand, ultrasound has a positive likelihood ratio of 12. So what are we looking for with ultrasound? So we're looking for something called B lines. These are bright hyperechoic vertical lines. They start from the pleura and they extend all the way down at least 14 to 16 centimeters. Some people describe them as laser-like lines. So they move with the movement of the pleura and they obliterate normal A lines. So to put this into perspective, we see A lines in the example on the right. A lines are a series of horizontal lines that descend deeper into the image and they represent reverberation artifact. So someone with normally aerated lung would have A lines. In addition to B lines, you can also look in the upper quadrants to see if you can see fluid above the diaphragm. This would be consistent with pleural effusion. In general, you want to scan 4 zones in each hemithorax, the upper and lower anterior lung zones and the upper and lower lateral lung zones. A positive finding for heart failure is the presence of 3 or more B lines in an interspace and 2 or more interspaces on each side of the chest. What else can you look for with ultrasound? Well, you can take a look at the heart to see if you can identify the etiology of your patient's heart failure. So for example, this patient has pretty bad biventricular failure. This example shows very severe left ventricular systolic dysfunction. The left ventricle is hardly contracting, the walls of the LV don't really appear like they're thickening, and the mitral valve's hardly moving. In this example, the left ventricle seems to have actually pretty reasonable systolic function. However, we can see that the posterior mitral valve leaflets prolapsed, and we see a lot of mitral regurg back into the left atrium. So this patient's got valvular dysfunction as the etiology of their heart failure. So how can you develop your POCUS skills? Obviously, you're not really going to gain these skills from listening to me speak in a webinar, but there are some very practical things you can do. There are lots of amazing free open access medical education resources online about point of care heart and lung ultrasound. You can also take an ultrasound course, and you should try to find one that emphasizes hands-on scanning time. If you have an ultrasound expert that works with you locally, seek them out, see if they'd be willing to provide you with ongoing long-term mentorship. Another option is to keep track of all the scans you've done and follow up and see what's actually happened with your patients to see if you have the diagnosis right or not. One last resource to direct you to is a recent CGEM Just the Facts publication. This just came out actually in July. It's about using point of care ultrasound and heart failure, and there's some Canadian representation on it with Paul Atkinson as one of the authors. So with that, I'd be happy to take any questions about point of care ultrasound and heart failure. And if there are not any questions, we can certainly move on to Sean Collins' talk, but I'll hand it back over. And like I said, if you have any questions, feel free to throw them into the chat. I'd like to introduce you to our first speaker, Dr. Sean Collins. He's a professor of emergency medicine and co-director of the Vanderbilt Coordinating Center, associate director of clinical trials in the Institute for Medicine and Public Health, and director of the Center for Emergency Care Research and Innovation at Vanderbilt University Medical Center in Nashville, Tennessee. His current research interests are in cardiovascular and acute care clinical trials. He's directed and served on several steering committees for international cardiovascular trials and has published over 200 peer-reviewed manuscripts. He'll be speaking about risk stratification tools to help you decide which of your patients in heart failure you can safely discharge from the emergency department. Dr. Collins, thank you so much for joining us today.
Thanks, Dan, for the kind introduction. Good afternoon, everybody. We're going to spend the next 10 minutes or so talking about acute heart failure, a little bit of a snapshot from a risk stratification perspective. So these are my disclosures, none of which will impact the content of this talk. So I want to start with a case briefly to get oriented as to patients that we typically see in the ER. A 76-year-old lady with a history of heart failure and hypertension. She's had dyspnea on exertion and orthopnea for 3 days. She came by EMS. She stopped her diuretic 7 days ago when she was out of town visiting family. Her vitals are as shown there. She looks well. She's in no distress. On exam, her JVP is slightly elevated. She has a little leg edema and some faint crackles. Depending on where you practice, you draw BNP or pro-BNP, and either one is elevated. Her chest X-ray does not show pulmonary edema, shows some cardiomegaly, but no signs of congestion. Her troponins negative, her creatinine is at her baseline of 1.5, and her sodium and potassium are normal. So you know that from talking to her, she's supposed to be on 40 milligrams a day of furosemide at home. You give her 80 milligrams. In the next couple hours, she produces a liter of urine. She gets up and goes to the bathroom, notices that her dyspnea on exertion has improved quite a bit. And the question is, at the end of your stay, at the end of this 3 to 4 hour observation period, can this patient be safely discharged? So is this person a candidate for discharge? And we'll go to the polling, and I will give you a few seconds to, no right or wrong answers here. Click away. All right, we are in double digits. I will see if we can see. Perhaps. There we go. Is this person a candidate for discharge? 13 people, so the majority of people said yes. Okay, let's we'll discuss this in a little bit. And I have a second question following up on that. If when you're thinking and when you're contemplating discharge somebody, how do you come to this conclusion? Do you use a risk score? Do you use severity of the current presentation? Do you use ability to get close outpatient follow-up? Or is it a combination of those three? Again, we'll take about 20 to 30 seconds here to let some votes accrue. Again, no wrong answers. Be good for our discussion to see some participation. All right. All of the above and severity of current presentation. Great. Thanks to those of you who participated. I appreciate it. We'll talk about this over the next few slides. So our objectives for this talk are to talk about integrating risk scores in discharge planning into disposition decision-making for ED patients with acute heart failure, perhaps identify a subset of patients with acute heart failure who may be discharged, but understand at least my perspective on the two components needed in this approach, which number one is an objective measure of risk. And number two is once that patient has been identified to be below your risk threshold, the care transition plan in place for outpatient management, both equally important. So why don't we currently discharge ED patients with acute heart failure? Well, McCausland and colleagues did this survey, quite dated now, but interestingly, they asked them, what's your risk threshold for sending someone home from the ED with heart failure? And you can see the vast majority of physicians said that they want a less than 1% probability of 30-day mortality or medical complications / AEs. So the summary of that article was really the ED physician wants 30-day mortality, quite similar to what we think about when we risk stratify patients with possible ACS. So the question is that reality or not with patients with acute heart failure in the ED? This is a review of prior studies looking at patients who were discharged from the ED. And you can see, depending on the cohort of patients and location of the study, the 30-day mortality in patients who were felt to be low risk were somewhere between 3 and 4%. So a high-risk patient population to start with, and for that reason, I think an objective measure of risk is very helpful in providing a foundation to consider discharge or not. When you think about the prior risk scores, there are really probably 4 studies to consider. The eMERGE risk score from Doug League and colleagues, the Ottawa heart failure risk score from Ian Steele, the MESI score from Oscar Meyer in Spain, and then our Stratify risk score, which was developed in the US. I think there are trade-offs to all these scores. Some look at just mortality, some look at mortality plus significant events. You can see the areas under the curve. There's some trade-offs between the 4 scores. I think it depends on what you're comfortable using, what you have access to, and what risk you're trying to predict, whether that's 7 or 30 days and just mortality or not. So I want to talk about the eMERGE score. I think this score is, as you'll see, been well derived and validated and ready to use. It looks at 7-day mortality, though Doug and colleagues did extend this to predicting 30-day mortality. A large cohort of patients, 7,400 in the derivation study, 5,100 in the validation study, both with very good C statistics. Importantly, it's available on MD Calc. And these variables, as you see here, age, EMS, blood pressure, et cetera, are readily available during your ED workup, making this a tool that I think is fairly straightforward to use. So it's interesting, if you look at the cut points from a risk score perspective. So eMERGE looks at 7 and 30-day mortality, but a score of 3 or less gets you in this less than 1% 7-day mortality. If you remember those prior studies, the outpatient mortality in patients' discharge from the ED was the 3 to 4% range. So again, this score of 3 puts you under 4%, a score of 2, less than 2%. And you can see how this is meant to be used. So physician estimated risk is the green line with an AUC of 0.71, the eMERGE score itself, 0.81. And I think when combined, especially when you think about the next step of this, using something like a risk score with physician estimated risk and thinking about next steps is probably the biggest bang for the buck. Why does eMERGE work well? You can see physician estimated risk in green, eMERGE in red. At the lower end of the spectrum, physicians tend to overestimate risk, hence our hesitancy to send people home. Interestingly, at the upper end of the spectrum, we may underestimate risk. So the eMERGE 7 actually nicely calibrates risk on both ends of the spectrum. So what was our patient score? If you plug these variables in, this gives her a score of 2 and a 0.7% risk of 7-day mortality. So depending on what your threshold is, this is below the 1% threshold and someone you can consider safe for discharge. However, that's only half of it. I think the key part is what's going to happen after discharge and having a transition plan in place. That plan could include addressing reversible causes. In Our Lady's situation, not adherence, readily identifiable. Restarting her medications will make a big difference, but arranging close follow-up and even providing some measures of education for the patient. We looked at this concept in a randomized trial a couple of years ago. We looked at a self-care intervention on 90-day outcomes in patients with acute heart failure who were discharged from the emergency department. The goal of this was to test the impact of our self-care intervention on outcomes in those discharged. Our intervention was a home visit, so they left the ER. We actually went to their house and visited them, and then followed that up with coaching calls every 2 weeks for 90 days. Our primary outcome was a composite of CV death, heart failure events, which were hospital admissions or ED revisits, and then the quality of life on the KCCQ score. So to get into our study, you had to have acute heart failure and have a prior diagnosis of heart failure. So those with de novo presentations were not eligible. You had to be discharged within 23 hours from the ED or ED OBS. And then we excluded people with blood pressures less than 100, with ACS as a precipitant, and then someone who could not adhere for whatever reason, an unstable home situation, lack of use of a phone, et cetera. So inability to adhere to our process. You can see we assessed over 7,100 patients. The vast majority of those were excluded because they were admitted to the hospital. We randomized 491, 245 to usual care, and 246 to the intervention arm. What our results show? Well, you can see here, our primary outcome at 90 days did not have a significant benefit. So a hazard ratio that crosses 1 with a p-value of 0.28. However, at 30 days, there was a significant difference between the intervention arm and control arm. And why was this? Well, we postulate that you can see these are our Kaplan-Meier curves, and they separate early and then come back together later. So early on, a lot of things happened that I think benefited the patients. We got them follow up with their physicians. We saw them in their house. We started early coaching calls. So I think this first 30-day window was rather intense. And then it ended up being just coaching calls, and perhaps that's why the curves came together. So it was really a simple transition plan that I think we can utilize in everyday practice as well. Our transition plan focused on a couple of main things. Do they have access to medications? That means being able to afford them as well. Can we get them follow up in the next 7 to 10 days with any provider? It doesn't have to be a cardiologist, someone who feels comfortable managing heart failure. And then can we provide a component of education, weighing themselves so when their weight goes up, they call their doctor, salt and water adherence, et cetera. So 3 main components to our transition plan. So who do I send home, or who do I consider sending home? I think the 2 components, again, are looking at a risk score, depending on where you practice and what you're comfortable with. There are several to choose from. In our specific case, we used the eMERGE to look at 7-day mortality. At a minimum, as in our study, ACS as a precipitant is obviously a high-risk situation. And those patients with lowish blood pressures, less than 100, are probably a little bit different beast to discharge than someone with well-preserved blood pressure. Identifying a fixable cause is very nice. It sort of clears up the muddiness of the presentation. This lady obviously had not been taking her medications for 7 days. That's an easily reversible cause. Give her a dose of diuretic in the ED and restart her medications. Blood pressure is another reversible cause, as in restarting their blood pressure medications while they're in the ED. Again, a good response to ED therapy is important. So let's say I check all the boxes, her mortality is low, I find a reason for her decompensation, but she has 20 pounds of volume on board. Even if they have a good response in the ED, it's a difficult patient to manage in the outpatient setting, and they'll likely have to be admitted just for this fact of needing a long-term IV therapy from a diuretics perspective. Then, as we just emphasized in the last few slides, it cannot overemphasize this enough. A plan of care and close follow-up is crucial for safe discharge. And so collaborations with outpatient providers is a key component of this, or setting the patient up who doesn't have a provider with a first-time visit prior to leaving the ED. And I believe that is it. Happy to take some questions.
Yeah, if you have any questions for Sean, just feel free to throw them into the chat box. Yeah, I was kind of actually wondering, Sean, I mean, do you think that physician gestalt in terms of determining the patient's risk is good enough, or do you think that we should be using these sort of objective risk scores?
Yeah, it's a good question. I think 5 years ago, there wasn't much of a choice, or maybe 7 years ago, it was a lot of gestalt, and that made it a little bit more challenging. I think most of the time, these risk scores actually support your gestalt. It's when they go in different directions that I think it should have you should pause and reconsider. The tricky part about heart failure patients is that they can look very, very well and have a very high mortality risk, and look very acutely ill and actually have a very low mortality risk. So it's a little bit inverse to how they present, which is not typical in the emergency room. Usually, what do they look like from the door goes a long way. It's not always the situation in heart failure. There are a couple questions. With these risk scores, do they take into consideration a change in meds in the ED? Great question. So in our study that I presented, we actually would try to talk with the heart failure provider and typically think, like, let's say the person's on 40 BID of furosemide at home, put them on 80 BID for a couple of days, and then go back to the 40 BID with the sense that there's a little bit of extra volume on board that we want to get off, and want to make sure that they're transitioning to euvolemia as they go see their heart failure provider. Matt Rowe asks, any advantages to one risk score versus another? I think ease of use is the key. I think they all have similar predictive abilities, especially at the lower end risk. So identifying someone who's low risk for mortality, but things like the eMERGE, and I think even the Ottawa score are available on MD Calc. So having something that you can readily use on your phone is key. For instance, Stratify, our risk score, is not on MD Calc. So we're implementing this in the EHRs of some hospitals where the EHR can do the computations for you. But I think they all do a reasonable job of looking at mortality. I think it depends on ease of use. It's a good question. Which score is commonly used in the ED? I don't know that off the top of my head. I think it may depend on where you practice, right? Oscar Myro has done a nice job disseminating his rule in Europe, so that may be used a little bit more. I think the Emerge and Ottawa scores are very good. I'm hoping the Stratify score will be used more in the next couple of years as well.
Do you get the sense, Sean, that heart failure is sort of perceived as a relatively high risk diagnosis in the United States compared to Canada? Just looking at some of the slides you put up, I noticed that the admission rate seemed to be, more along the lines of 80 to 85%, whereas in Canada, that rate seemed to be a bit lower in the 70% range.
Yeah, I think it has. I don't think the patient populations are that much different. I think that's exactly it. At least in the US, I think link acute heart failure with ACS. It's a cardiology sort of disease and blur that risk a little bit. I think in Canada, they're probably a little bit more aware of what the risk scores. Two of them have been developed there, obviously. And so probably using that in their clinical practice is a little more common. But it's a challenge to overcome that. Also, it's not a difficult admission where I practice. 90% of patients get admitted with heart failure, and there's not a lot of discussion versus what if this was chest pain? I think you get a little bit more pushback or more inertia to discharge the patient.
One person has a comment that their small Emerge doesn't have BNP. Or the ability to measure that. And then someone else, Katie Lynn, asked, how important is it to identify the cause of the acute exacerbation?
Good question about the Ottawa score. I think there's one with and without BNP, but you're right. I think the natriuretic peptide does add some prognostic accuracy. I think that to Katie's question about exacerbation, it's very reassuring if you can identify something. If you check the boxes of, okay, they swear they're taking their medications, they've been eating appropriately, their blood pressure is good, and I'm not quite sure what the cause is of their precipitation, that's what gives me pause. Like, is there something going on? They have worsening EF, they have something smoldering like infection or ACS in the background. I feel much more reassured when the person's like, I apologize, doc. I went on a flight last week and I stopped my diuretics because I didn't want to have to get up and, go to the restroom being on vacation. That makes me much more reassured when I know I can restart this, address the precipitant in the ED. Yeah, I'm sorry. Josh is asking about looking well. So ironically, the patients who come in with hypertension and pulmonary edema on BiPAP, I may have to intubate them. They look really sick. They get better dramatically in 6 hours. That person who looks like they are on death's door because of a lot of their underlying, they have HFpEF, they have well-preserved EF, good blood pressures, et cetera. They actually might have a much lower 7 to 14-day mortality risk than the person who comes in looking well with a blood pressure of 135, not hypoxic, but has been gaining 20 pounds over the last couple of weeks, has an EF of 15%, a creatinine of 2.7, which is kind of their baseline. So it's interesting how the look from the door can fool you a little bit with patients with acute heart failure, I think. Great questions. This is not an easy topic. We've made a lot of progress with natriuretic peptides. You're going to hear from Jonathan shortly about the new medications and how they've made a dramatic impact in mortality and readmission. So I think it's an exciting area to be in, especially at the front door. We have a big opportunity to impact a lot of patients with acute heart failure who are transitioning to chronic heart failure.
I guess I just want to highlight one additional thing that Katie asked in her question, because you said if you can identify the cause of the patient's heart failure, that makes you feel good. But what if you can't? Is that patient at higher risk?
I don't know that they're necessarily at higher risk. Again, we sent people home in our guided study with not obvious causes. We suspected what they were, but maybe they didn't have a glaring, like I didn't take my furosemide for 7 days. But it does make me think twice about sending them home because I don't have that reassurance that I'm addressing their precipitant by doing X in the emergency department. I don't know of a lot of risk scores that take into account precipitants, unless it's ACS, obviously, which I think most people know that that is a pretty high risk precipitant.
Okay, fantastic. So I think we can move on. Next up is Dr. Jonathan Howlett. Dr. Howlett's a clinical professor of medicine at the Libin Cardiovascular Institute and Cummings School of Medicine at the University of Calgary. He practices as an advanced heart failure cardiologist and has been heavily involved in clinical practice guideline generation and knowledge translation related to acute and chronic heart failure. He's a former president of the Canadian Heart Failure Society, Canadian Cardiovascular Society Heart Failure Guidelines Chair, and he currently co-chairs the annual Canadian Heart Failure Society update. He'll be speaking about old and new medications in heart failure. Dr. Howlett, thank you for taking the time to speak with us today.
Thank you very much. It's a pleasure to be here. Thanks for having me. Thank you in advance to Sean, who lost the coin flip today and has agreed to therefore advance slides so that we don't have a lot of technical delay. So with that in mind, next slide, please. These are my disclosures. As you note, we've gone from relatively few disclosures to a ton of disclosures. So if you're not sure about anything that I say, I think it's safe for you to assume that there's a conflict, and keep that in mind. Next slide. We're going to talk about three things. Part of that, and I had one question here just in advance to Sean. I think I'm going to just read the question and the answers. I don't want to use any extra time waiting for the poll. I want to make sure that there's a chance for people to ask questions for either yourself or Dan or myself at the end and still have time. So we'll just go through the presentation here. So by now you've had a chance to read the three objectives. So we'll talk about new and old heart failure drugs. I'll just touch very quickly on chronic heart failure medications. Talk about progression of disease briefly, and then maybe some rethinking about that. Next slide. So the first is, what do we need to know about new and old heart failure medication? So next slide. This is our case. It's a longish case. On the left, notice this is somebody whose ejection fraction was 28%. It rose to 45%. There's a new universal definition of heart failure. This person's now considered to have heart failure with improved ejection fraction, but he still has heart failure. And as you can see, developed atrial fibrillation, and then that's when all the doors fell off. He comes in, he's satting okay, like most heart failure patients do, and has evidence of excess fluid. Blood pressure just under 100. Pretty consistent diagnosis of heart failure. It's pretty certain. Now, one thing that I want to emphasize, everything else I'm going to talk about, these are about patients who have either new onset heart failure or worsening chronic heart failure. They do not have ACS. I just want to make that very clear, and that may be important in some of the further comments. If you look on the right side, well-treated chronic heart failure patient, they were not stopped because his ejection fraction went up. That's a common question we get. The stopping meds when the heart function gets better is kind of like stopping a treatment because it's working, and so we don't do that. Next slide. Here's the question that I gave to you. There are 6 potential options for this gentleman who presents with quite a bit of fluid overload. And just consider to yourself what you might have thought. There's reasons to pick any one of these 6, but there's also good reasons why you might not want to pick them either. So some would say, okay, nitrates until proven otherwise. Someone else would say the most important thing by far is to get rid of the volume. That's why he's here in the first place. And then things like specific therapies, he should be on an SGLT, he should be on no beta blocker because he comes with decompensated heart failure, or perhaps alternatively on an IV inotrope, or his sacubitril valsartan should be stopped because his blood pressure is 95. Next slide. So this is our slide. Oh, thank you very much. Thanks, Sean. So if we could go there. These are the couple of slides on chronic heart failure I'm going to show you. I thought it would be of interest. This is what's kind of top of mind in the heart failure literature right now. This is an amalgamation of over 100,000 patients worth of data in various classes for heart failure, chronic heart failure, where, as you can see on the x-axis, ejection fraction is listed all the way from 15 to 75% because there's a variety of different trials involving these therapies. They're all placebo-controlled controlled trials. And on the y-axis is the hazard ratio, and these are all regression curves. And you can see that in general, most heart failure therapies actually benefit most patients with heart failure. When we get into the higher ejection fractions, those benefits are much more difficult to show, and in some cases, they're completely absent. Notice that beta blockers are not listed here. That's because they don't have straight lines when you do the regression. It looks like a hockey stick that really jumps up at around 45%. And so the beta blockers are the exception to this. Notice on the top, and this is all very new, it's very top of mind, the SGLT2 inhibitors, dapagliflozin and empagliflozin, those are the two that are most studied. Look at the regression curves. They appear to benefit patients irrespective of ejection fraction, and that's going to make a difference in our treatments. Next slide. More recent studies have, let's see if there we go. Okay. And because of that, we now have heart failure with low ejection fraction, that's less than 40%. It is a 4-drug disease. It's not a 3-drug disease, it's a 4-drug disease. It used to be beta blockers, mineralocorticoid receptor antagonists, or spironolactone, eplerenone, and the RAS inhibitors, either an ARNI or an ACE-ARB. With the ARNI, that's sacubitril/valsartan, is the preferred drug, and now SGLTs are part of that club. And then the additional drugs are the next line, and these are where the art of medicine is still very, very active. Next slide. So what about acute heart failure? These are all chronic heart failure trials, and maybe they don't really apply. We've tried many, many times taking chronic heart failure medications and applying them to acute heart failure, usually without success. Next slide. So in acute heart failure now, we have some data. This is fairly recent. This is a study of people with low ejection fraction admitted to hospital with heart failure, and it's whether or not you switch their ACE inhibitor to the ARNI. And as you can see on the right, they have an immediate benefit in BNP, and they have which means they're being decongested approximately twice as quickly or thereabouts. And on the right, that translates into fewer readmissions because congestion is a dominant factor in predicting what happens to these patients. So once they leave your care and they're still congested, that's an increase in risk. Next slide. This is another SGLT inhibitor that's available in the States, but not available in Canada. This was a study where they were prescribed at the very end of their hospitalization or within a couple of days. And look at the bottom left of this curve. You can see there's a clear benefit. The number needed to treat here is like 7. That's an amazingly low number. And these curves begin to separate within 10 days. These drugs work very, very quickly. Next slide. And the upshot of all of this is evidence-based therapy should be given earlier. And in the case of SGLTs, it does not seem to matter what the ejection fraction is. There seems to be a benefit, and it's not just a hospitalization benefit. There's also a cardiovascular mortality benefit, and you're going to see that. Just advance the slide one more so you can show my lovely, and one more that you can show my lovely slide making skills. And I will also say this, too late to put into the slides, but a study was just stopped late last week called the STRONG-HF trial. And in this study, patients were randomized in hospital to either an accelerated, aggressive regimen to titrate medications or to usual care, and the trial had to be stopped because of evidence of benefit. We're going to learn more details about this study in November at the American Heart Association meeting. But in the meantime, we are now accumulating very, very critical evidence and powerful, large effect size evidence that says you should be aggressive when possible with evidence-based therapies. Next slide. So the chronic drugs are being translated into the acute situation, and we're finally able to show that. Next slide. So what happens when people go home? This is actually kind of old. This is 10 years old. But look at the congestion score. The higher the congestion score, the worse the more congested patients are. And look on the right side, what the all-cause mortality and heart failure hospitalization rate. That's all-cause mortality and heart failure hospitalization rate. And look at the first 3 months. These people have event rates of over 20%, and the event rates are, even if they're relatively decongested, still fairly high, as to Sean's point earlier. Congestion equals increased events, bottom line. Next slide. Another thing is, should we stop medications when people come into hospital? This is data from the Get With the Guidelines group in the US. Some of the data cuts here show various drugs. I forgot to label them. I'm apologizing about that. One of them is for MRAs, another for beta blocker, another for ACE, and another for ARB, and they all show the same thing. Notice that the two top lines with the worst outcomes they occur in patients who either had the drugs not started when they came into hospital, or it was stopped. Okay, and it's as if you were never on the drug if they're stopped in hospital. So don't stop these medications unless there's a very good reason. The evidence, and there's several other registries that show exactly the same thing. It's critical to continue evidence-based therapies unless you feel like they just can't be continued. Next slide. Another thing that I want to point out to everyone, and as emergency physicians, I think you probably knew this all along much better than the medical specialist did, actually. There's a huge overlap between heart failure and COPD. And so if you think you have the answer and someone's in your emergency department with shortness of breath and you say, they have heart failure, remember, that person has about a 30% chance of also having significant COPD. And the corollary is also true. Keep that in mind. This is a potential therapeutic option for you to at least raise and think about, especially for people over the age of 40, which of course is most heart failure patients. Next slide. Here are a few situations, and you can have a copy of the slides because I'm going to go through this fairly quickly. Here are a few scenarios and the kinds of things that I think of. Now, you may not do this while they're in the ED because of limited time, but there's certainly things that can be done when they're discharged or when they go home. So people with low blood pressures tend to respond well to mineralocorticoid receptor antagonists or ivabradine and digoxin. SGLTs really don't lower blood pressure very much. These are the difficult patients to treat. And in terms of renal function, ivabradine, vasodilators, beta blockers don't really affect renal function. Their efficacy does not alter according to renal function. So there are options out there, and it's important to recognize the limiting factors for each of these drugs, because there's now about 10 different drugs that we can choose. There's the 4 foundational therapies, and then there's 5 or 6 others that we can add to later, including the investigational drugs vericiguat and omecamtiv, which I'm not going to talk about today because they're not available in Canada. Next slide. What about common therapy? So the most, you may already know, next slide, you may already know that the most common drug given to a person in emergency room, this is admission and discharge, but in emergency rooms in Alberta, the most common drug given to somebody who presents ultimately with heart failure is actually Ventolin. And of course, it's because they just show up. We do what we can do while we wait for tests and for assessment. It's understandable. But interestingly, most people think that the most common drug given to people with heart failure at the time of discharge is actually an ACE or an ARB, and it's not, as you can see here. It's always diuretics and beta blockers are number 1 and number 2. We see a lot of isosorbide dinitrate, that's ISDN, that's a nitroglycerin preparation, and then the other drugs very infrequently used. Remember, about 40%, nearly 40% of people who go into hospital with heart failure have a low ejection fraction, and yet less than 10% are on the ARNI, which is considered to be twice as effective as an ACE inhibitor. So we still have a lot of work to do. These are in Canadian tertiary care centers. So these are not in hospitals that are small hospitals that don't have BNP. This is in places where there's a lot of resources available. Next slide. This is the one slide I wanted to really focus on in terms of older therapies. This is a vasodilator therapy. It's called the Galactic trial. It was multi-center. It was predominantly a European trial. And what they did is they randomized patients to an aggressive vasodilator strategy. They could still use diuretics as they thought appropriate. Most commonly used, nitrates and hydralazine. Other vasodilators were also allowed. And just to very briefly mention it to you, they did have a very aggressive use of vasodilators, which tapered off towards the end of the hospitalization because of hypotension. And as you can see on the right side, this is the largest and best study done to date. It's almost 800 people, and still this would be the 5th randomized trial in a row that has failed to show a significant benefit of nitrate therapy in acute heart failure. And in certain parts of the country and here in Canada, especially here in Alberta, nitrates have really been aggressively promoted for heart failure. They may be fine for acute coronary syndromes, and I would never interfere with that. But for chronic heart failure or acute heart failure without ACS, does not really seem to be much benefit at all. Next slide. In fact, it may interfere with your use of other evidence-based therapies. So this slide is a list of interventions that have been looked at in the inpatient hospitalization that have event rates that are lower at follow-up. And notice that 3 of them are medications and 5 of them are process, as Sean alluded to earlier. Very, very important. And with really, really good numbers needed to treat. Next slide. I'm going to skip this slide here. Order sets are useful, and I'm going to go straight to this. This is data from Alberta. It's a heart failure care pathway that is implemented at discharge, at emergency discharge when they're admitted to hospital. And as you can see here, the event rates at 7, 30, and 90 days are much, much higher before our implementation occurred in the brown. For those who had the usual care in matched hospitals, had higher event rates, and those who had the full pathway involved actually had the best outcomes. So these care pathways will be very important in making sure the right patient gets the right treatment at the right time. Next slide. Last, I'm going to point out that in large randomized trials, when people go to emergency, they don't live happily ever after. Outpatient worsening heart failure ED visits have almost as high an event rate as those who are hospitalized when you add in rehospitalization rates. So yes, patients do need to go home, but they do need an exit strategy. They can't simply be discharged. Next slide. Next slide. Okay, so back to Mr. Wet Rag, and the last slide is the next one after this. Hopefully I made the point, don't stop their medications. Just advance one more slide. Don't stop their medications. I would have chosen number 2. There's reason to choose any of them. Next slide. And that's because we need to decongest this gentleman. So I'm going to hand it back to our chair. If there's time for some questions, I'll leave that up for a second. And hopefully you got a couple of useful nuggets. You're certainly welcome to have copies of the slides if you want. And thanks for your time.
Yeah, thanks for that, Jonathan. That's super informative. Someone's asked, are the SGLT2 inhibitors only being used in diabetic patients with heart failure or all comers with heart failure?
All comers.
Okay, so all comers.
Yeah, these drugs, their benefit in cardiac and renal have nothing to do with the blood sugar lowering effects.
So yeah, I mean, if you have more questions for Jonathan, please throw them into the chat box. Or if you have any questions for myself or Sean, yeah, feel free to toss them in the chat box. I'll just address actually a question that was asked earlier about how much practice would a typical emerg doc need to become competent in point of care ultrasound for assessing the lungs. There's a study that was done several years ago where they sort of looked at this, and they kind of determined that you probably need to do about 25 scans to become reasonably accurate. So you're probably looking at maybe 4 to 6 hours of supervised scanning with a couple hours of actual sort of classroom teaching. So yeah, I mean, it's certainly feasible if you have, if you can do a course or if you have that sort of framework around you. I guess a question for Jonathan about so you're saying that in terms of changing people from an ACE to an ARNI, that's sort of the recommendation. Do you have a sense, is there like a price issue with the ARNIs at all?
Yep, there sure is. For ARNIs, the best evidence is for EFs under 40. Keep that in mind. It's a low ejection fraction drug. ACE inhibitors now are, I don't know, between 30 and 70 cents a day. An ARNI would be more expensive. They list for $7 a day. The actual cost, no one knows because it's kept confidential, but we think it's under $5 a day, and we know that the cost of SGLT inhibitors is about $3 a day. So these drugs do cost money, and they're definitely not free. However, they are covered in every province in Canada for these indications.
So Dominic LaRose, he's asked, because obviously, Jonathan, you really emphasized the importance of properly decongesting the patient before discharge. He asked, how do you assess that the patient's appropriately or properly decongested? Is there any sort of scoring or any sort of any tool to help with that assessment?
Yeah, good question. So there are congestion scores. In both the Canadian Cardiovascular Society and the Heart Failure Society of America have criteria that are suggested to be ready for discharge. So no requirement for supplemental oxygen, JVP under 6 centimeters above the sternal angle, very few or no crackles, edema mostly improved, patients ambulatory, feeling back is fairly close to their baseline. Those are the general criteria, and then there's a few laboratory criteria. There's actually some POCUS studies as well that show that higher congestion scores, higher numbers of B lines are associated with a higher readmission rate. We just hasn't made its way into guidelines yet with a cut point. BNP drop of about 30%. Many groups, and we do in Alberta, we recommend a BNP on admission and discharge because we know that those who have a BNP drop of more than 30% while they're in hospital do much better. And you can focus your efforts on the other ones who don't drop, because there are some who actually gain weight and actually gain BNP while they're in hospital. They're the real hardcore cases that are difficult to treat. So there are congestion scores out there. Most of it is, in terms of the guidelines, is common sense, and that will be an evolving field over time. Good question.
Margaret's wondering, what's the mechanism by which SGLT2 inhibitors work for heart failure?
Yeah, I was actually hoping that Sean could tell us, because I sure as hell don't know. There's a lot of literature on this. Everything from it's a fancy diuretic to it has renal effects that are causing downstream reduction in sympathetic activation. Others are saying that it alters glucose metabolism. And then finally, I would say right now the leading, not mine, but the leading candidate is something called inhibition of NAHK3, which is a membrane protein that's found on almost all vascular tissue, heavily in the kidney and heart in particular. And the interesting thing is most heart failure therapies that work in low EF, including beta blockers even, actually have a downstream effect on this protein molecule. So we'll see. I don't know, but you can really make yourself a good reputation if you figure it out.
It's funny. We Jeff Testani is probably one of the world's experts in cardiorenal syndromes, and he has some data that we're submitting that exactly, you hit it right on the head, Jonathan, suggesting tubular glomerular feedback and kind of where the natriuresis and diuresis occurs in the tubule is probably the key to why these things work so well, and cause a little bit of natriuresis and diuresis, but don't cause this RAS crazy activation that other diuretics do. So
that's my leading candidate too.
Yeah, it's like it's a wonder drug. It's unbelievable. And I was interested what your thoughts were about starting them earlier too. I mean, it looks like now we're going to be starting them in the hospital, newly in patients as they get decongested prior to going home, et cetera.
Yep, totally agree. Didn't have time to get into it, but there's 2 studies that show exactly what you said. Another one that shows improved quality of life. Better diarrhea. You get about an extra 800 mils of diuresis the first day you give it, and then it stays. You don't lose it later on. These are we're going to learn a lot more about these in the future, but you don't get, and that's the other thing. With a lot of these RAS therapies, you kind of worry about giving them when the EGFR is around 30 or below. Should I give it? Shouldn't I give it? Well, if you give an SGLT and the GFR is 20, the only question in my mind is it worth it or not? It's not whether it's dangerous, it's whether it's worth it or not, because you get this short-term 10 to 15% reduction in GFR, but then that's all you get. And if you get progressive renal dysfunction after an SGLT, then look elsewhere for your problem, not with the SGLT, like usually the diuretic or something else.
So I've noticed in the box, we've got kind of two questions that are actually sort of similar from Jennifer and Josh. So this is probably for Jonathan. Both of them kind of said that they're a bit surprised about the de-emphasis of nitrates in terms of acute treatment. But I think the question seems to be more focused on, when people come in acute heart failure exacerbation, are quite sick, you need to provide immediate intervention to help address their shortness of breath in the emergency department setting, in more of an acute setting rather than necessarily their inpatient admission. People were wondering about your thoughts about that.
Yeah, I figured I'd get some pushback on this. So you have to you have to be very mindful of who got into these studies. And that's why I qualified what I said. The early studies supporting nitrate use, Cotter et al., those old trials with the roving ambulance treatment centers, they did not rule out ACS. You can't in an ambulance. And it turns out that a high proportion of those patients, and I would also point out they're very small trials, okay? So very frail results with a small trial. And they did not rule out ACS, and a lot of those patients actually had ACS. So someone with ACS, particularly if they're hypertensive, nitrates all day long until you get a definitive therapy. Absolutely. And that's why I wanted to make very clear that I'm not talking about those patients. Secondly, the acute hypertensive patient that Sean talked about earlier, and that's referred to in the chat, they do exist, and you need to get the blood pressure down. Whether it has to be a nitrate or something else, well, nitrates are the easiest to use. And these patients really don't get into these heart failure trials. Number one, it's a relatively uncommon presentation from a heart failure perspective. It's only if you look at the worldwide registries, it's only about 1 or 2% of heart failure presentations is acute hypertensive critical crisis. Okay, and then secondly, once you take care of them or get rid of them out of your cohort, then you're dealing with people who are mildly hypertensive, and so it's a different game. So I think it's a lot of it's about the patient that you're seeing, and I would never suggest that you avoid a nitrate in an acutely hypertensive patient or in an ACS. Hopefully that clarifies. Sean, you may want to add to that. You spent a lot more time in
100% agree that this is how I view Christian's study, is that they didn't necessarily enroll the hypertensive pulmonary edema patient. They enrolled patients with normal blood pressures and were very aggressive reducing those. And as you said, perhaps precipitating hypotension. And so hence why there was maybe some untoward events versus the hypertensive pulmonary edema patient on BiPAP. I completely agree. This is a good person to use nitroglycerin. They get better quickly. You get them off nitroglycerin. They don't go to the ICU. I love that approach.
Dan, could I answer that last question? I have something that I think you guys might be interested in. Is it okay?
Yeah, sure. Perfect.
It says redistribution versus total volume overload. So number one, weight changes only occur in about 40% of people who get worsening chronic heart failure. So weight changes, just like most things for acute heart failure. If you see it, it really helps you. If you don't see it, it doesn't help you. That's why lack of crackles doesn't rule out heart failure, for example. Secondly, the biggest blood pool in your body where blood is stored is actually in the splanchnic circulation in your belly. And it's like the bullpen in an airport, where all the cabs wait and then pick somebody up. So the circulation is the car coming to pick you up at the airport. The bullpen is the splanchnic circulation, where all the cabs are waiting for 3 hours. And the current thinking is that in many of those patients, it's redistributed from out of there for whatever reason, usually vasoconstriction. And there's actually studies now that show if you block unilaterally the splanchnic circulation, and there's a nerve you can block there, believe it or not, they actually decongest, and patients can actually feel better. have less volume and can actually exercise longer. So I thought I would point that out because relatively new concept.
Oh, yeah, fantastic. I think we're sort of hitting the hour mark or just past. Thank you to our presenters for this very informative talk. Thank you, Sean and Jonathan. You've obviously provided us with pearls and tips for the next time we see a patient in heart failure in the emergency department. I'd also like to thank everyone who's joined us today. I'd like to thank the Scientific Planning Committee for their valuable input, the CAPE staff team for all their hard work behind the scenes, and our IT support. The session's been accredited by the College of Family Physicians and the Royal College, so please don't forget to complete your evaluation form and claim your credits. A certificate of attendance will be mailed out by CAPE together with the evaluation link. Finally, CAPE's got a very interesting lineup of live and on-demand educational webinars planned over the next few months, so please keep an eye out for more information. Plan to join us again soon. Thank you all again.
Thanks, Dan. Take care, everybody.
Take care.